post-operative rehabilitation. A manual therapy perspective. Very important is a manual therapy perspective. We know everything about the rehabilitation. Our PT schools, our basic schools have taught us about the rehabilitation, post-operative rehabilitation. Every student knows what post-operative rehabilitation is, but what important is what is a manual therapy perspective of it. So once we start a lecture, and once we go in deep diving this lecture, what about the manual therapy perspective is, we'll come to know what importance we can add apart from our general rehabilitative process. So rehabilitation process. So we have to add more things to the treatment for making the patient better. The most common surgeries after which patients benefit from post-operative surgical rehabilitations are orthopedic, uh, bone, joint, ligament, muscles. Can anybody tell about any surgeries which are related to orthopedic? In chat, if you can say which are the surgeries. In short, which are the surgeries? Because there are many surgeries. So anyone, total knee replacement, TKR, ACL reconstructions, arthroscopy. Yes. Related to ligaments, THR, arthroplasty. Related to muscles, anything related to muscles, surgeries related to muscles, quadricep plasty. Okay. But tender transfers, great. Meniscal tear, repair of meniscal tear, rotator arthroplasty, correct. Correct. This rotator arthroplasty are tendon and ligaments, including, correct. Muscle tears, basically muscle tears. So few doctors suggest after muscle tear there should be a repair of the muscles. They repair the muscles. So muscles also comes in orthopedic surgeries, obstetrics and gynecological, which is postnatal, hysterectomy, etc. Spinal and neurological surgeries, disc repairs and replacements, uh, yes, and brain surgeries and spinal surgeries. I just wanted to ask one more question. In spinal and neurological surgeries, are only disc repair, replacement, brain surgeries, and spinal surgeries are only neurological surgeries, or there are any other? Any other surgeries? Craniotomy, cranioplasty, there are brain surgeries. PNI, what is deep brain stimulation surgery? What is PNI? PNI. Can you elaborate? PNI. Peripheral nerve. That's what. Peripheral nerves also come in spinal and neurological surgeries, peripheral nerve injuries. What kind of surgeries what we do in peripheral nerves? Uh, Decompression surgeries, correct. Nerve suturing, yes. Brachial plexus surgeries. Correct. Now transposition. Yes. So these are also the surgeries which comes in spinal and neurological surgeries. And we play very important role in rehabilitation of this surgeries. Secondly, abdominal and thoracic surgeries, which are lung, heart, liver, gastrointestinal system, and other organs. So other organs also. So pancreatomy, appendixectomy, uh, even this also are covered in abdominal and thoracic surgeries. Best risk resection and reconstruction, mostly done in cancer surgeries. So cancer surgeries and urological, which is bladder and prostate. So these are the common surgeries which patients benefit from post-surgical rehabilitation. Where does it take place? Where does it take place? Where in the acute phase, post-surgical rehabilitation usually starts right away after surgery in the hospital. That is acute care. I just wanted to know from you all. You all work as a practitioner, full-time practitioner. You work in the hospitals. I just wanted to know from you how after how many days your surgeon asked you to start the rehabilitation post-surgery. From day three, immediately 0 to 1. Okay, day one, usually 24 hours post of depending, yes, depending on the surgery, but why depending on the surgery? What surgery is there? How is the state of the patient? Does it depend on the state of the patient? Is he comatized? Is he under anesthesia? What orthopedic surgeries most probably consciousness. Do we do rehabilitation? Depends on conscious. Do we do rehabilitation for subconscious patient? I can't say it is unconscious patient, but subconscious patient. No. Why no? I think we do rehab. Yes, we do. Yes, we do. For ortho surgeries, yes. Even for the other surgeries also we do. Even uh, chest PT also can be done to avoid further complications, which is post-surgical 5 to 6 hours. Even if the patient is subconscious, we do it. We do it. So post-surgical rehabilitation usually starts right away after the surgery in the hospital. That is acute care. That is what is written, and continues at your physiotherapist office or your home, like at the patient's home or at the clinic. Usually chest physiotherapy and therapy. Yeah, yeah, that is what I said. That is what I said. Chest PT for the vendor. That is also a physiotherapy rehabilitation process, post-operative. First rehabilitation steps at a hospital, movement assistant, helping and teaching you to move safely, uh, advising and teaching you to use the mobility like crutches, aids like crutches. This rehabilitation takes place after when the patient is consciously oriented. He is moving around. His strength is somewhere around 3 out of 5 is working against the gravity, and then you start to uh, advise the on the mobility aids and crutches and movement assistance. Movement assistance is given when helping you to teach move uh, on the sides, roll in the bed, getting up from the bed. So movement assistance, splinting and slings, sometimes post-surgical orthopedic surgeries or even cardiac surgeries or even any surgery, splints are given and they advise you how to use the splints. So if the splints are given and in hospital care, the nurses or the other persons helps you with splints and slings and the person is alone at home and he doesn't get any help, he is not able to help use the splints and slings, so he is advised how to use the splints and slings. And lastly, not lastly, it is the first thing, breathing exercise. We'll be given some tips on how to breathe properly to avoid respiratory and vascular complications. We'll see in further slides what complications or vascular complications or avoid respiratory complications, how it is important. And if there are respiratory and vascular complications, then the hospital stay is prolonged. So we don't want the patient to stay for longer duration of time in the hospital. Even why it is required for early discharge of the patient apart from our rehabilitation process. Anyone, why it is required for patient to get early discharge from the hospital to avoid what? Anyone? Uh, Better environment with loved ones, nosocomial infection. Nosocomial infection, financial burden. So many of the things are important that prolongs the hospital stay. If it prolongs the hospital stay, then there is a secondary complications. There are secondary infections, nosocomial infections, and the burden on the patient. Yes, correct. Further rehabilitation advice when the patient is ready to go to the like getting discharged, the doctor will explain what is the outcomes, what is to expect from the upcoming weeks and months. Sometimes this is a practical issue. The patient comes home and they call you and they say to you that it is a very emergency that the doctor has said you shouldn't be wasting even a single day, and however whatever time is possible for you, just come for the physiotherapy because doctor wants early recovery. They don't know what is early recovery. The recovery time is going to be set should be set by the doctor itself, by the surgeon itself. But but the patient doesn't understand that things. The patient will keep on calling you until and unless you visit them. So the surgeon should explain what should be expecting in upcoming weeks, months together, and what should be the treatment plan. Treatment plan. Discharge advice. You will be informed about any necessary equipments and tools you will need at home for your rehabilitation because uh, the hospital beds, crutches, uh, some sticks, splints, any exercise material has to be required. If that is to be required, they have to purchase it or they have to keep it at their home. So when you visit their home, it will be easy for you for the rehabilitation process. And exercise, you might be taught certain exercises. See, breathing exercise, we teach every patient a breathing exercises, even if there is no thoracic or chest or heart related or lungs related surgery, even though other surgeries are there, then too we teach the breathing exercises and some of the basic exercises to the patient to perform at home. See, rehab advice is always, it will be hard and require commitment. Commitment, exercise and movement are key. Move to improve. Yes. Why you need post-operative rehabilitation? I have written the things, but anything apart from this, why you need? Sometimes patient think, see, there are many surgeries and there are many patients who get discharged from the hospital who knows what to do. They do it by themselves? Who knows the minimum exercises, but they are not committed to any rehabilitation process. They are not going through any process. They do it by themselves. And after 6 to 7 months, they take longer duration of time to recovery. And after that time, even the there are deficits, and they come back to you. They see you, and when you ask them that whether you have started whether you have started physiotherapy post operatively, they say no, we didn't did, we just did uh, basic exercises and we were moving, so we thought there was no need of any surgery, any post operative rehab. Have you come across any this kind of patients? I guess almost all physiotherapists have come across this kind of patients. They just ignore because might be a burden on them, might be a pressure on them, might be they might think that this physiotherapy might cause more pain, so they don't wanted to do it. Might be a economical burden on them, might be nothing to them, but they just ignore the rehabilitation process. So post-surgery physiotherapy and other rehabilitation treatments strengthens the joints, mobilize affected joints, muscles, and improve circulation and breathing. We'll come to these points. What is to be expected post-surgery rehabilitation? What is expected by the patient, and what is your role? What is physiotherapist role? Is manage your pain and discomfort, manage patient's pain and discomfort, regain your independence. This is for the patient. What is to be expected? Pain and discomfort, regain your independence, strengthen and stretch the muscles, improve circulation, range of motion, improve lung volume, prevent chest infections, return to your usual daily activities, reduce any anxiety and regain your confidence, increase comfort and reduce the risk of pressure sores. Okay. So any other things to be expected from post-operative rehabilitation apart from this all points? We are managing this pain and discomfort. We are giving them independence. We are increasing their mobility, increasing their balance, which reduces again their anxiety, improves the confidence of the patients, and comfort and reduce the risk of pressure. So reduce the risk of pressure source is basically return to the sports. Yes, for the sports injury patients or rehabilitation of the sports, return to the sports is very important. That is return to your daily activity, return to your usual daily activity. If the patient is sports person, then return to the sports. If he is a daily wager, then return to the activity what he is doing. If he is a if he's a homemaker, yes, then reduce the risk of contracture, societal reintegration. That is what we mean for regain your independence and anxiety and regain your confidence. Reduce re-injury chances. Correct. Emotional support. Improve the emotional support. Absolutely. Pain reduction or elimination. Pain is most common issue when recovering after surgery. There is a misconception that physical therapy can cause even more pain. This second point is very much important because most of the cases, most of the patients, most of the patients think that physical therapy, because they might have seen the patient crying when there is a rehabilitation process going on with with any of their relatives, or they see the patients crying, uh, and they think that they are physical therapists are causing more pain. So it's a misconception. Various treatment modalities and exercises actually help, and everybody knows, everybody has seen the patients. So various treatment modalities and exercise actually helps. It helps to reduce or eliminate pain, restore muscle and joint function. Better muscle function. Uh, as we are physical therapists, musculoskeletal is very important for us. So better muscle function, mobilization. I have written it, but immobilization happens to the muscle. What happens to the muscle? Due to immobilization, what happens to the muscle? Muscle contracture, muscles atrophy, correct? Reduce contractile ability, tightness, atrophy, stiffness, wasting, muscle wasting, absolutely right. So, what happens after immobilization is less number of sarcomeres are muscle fibers, and decrease in sarcomere in series. So, after immobilization for a longer duration of time, the muscle atrophy starts, and when this atrophy is there, the sarcomeres are reduced and the muscles are tight enough. Muscles are tight enough and less, and they are in atrophy, either in atrophy also is a vesting of muscles. So weakness, lethargic, sometimes that say weakness and lethargic can go off, but if there is a atrophy, if the muscle is thinned off, the strength of the muscles is reduced, the muscle tightness is increases, um, and hence we required better muscle function post surgically to improve the blood circulation around the muscles, around the joint, around the part where the surgery is to be done, and to improve the joint function movements, increase the strength of the muscles, increase the flexibility, increase the endurance, increase the endurance. Better balance. Surgery is a massive trauma to your body. Basically, after surgery, even neurological surgery, even orthopedic surgery, uh, there is a incoordination. Incoordination is basically seen in the neurological cases, post-surgical cases. So surgery is a massive trauma to your body. Incoordination, loss of static and dynamic balance. Patients tends to lose balance and falls. There are cases wherein even the patients are overconfident and tends to fall post post operative. So there are increase in number of falls post operatively, even uh, due to the loss of static and dynamic balance. So neuromuscular re-education that will help to this visits. Improved blood circulation, tissue perfusion. Surgery is a trauma, as you said. As I said, surgery brings you more of blood loss, more of fluid loss in your body. It might be even bone loss, even tissue loss during the surgery. So after surgery, post-surgical, you you spend a lot of time lying in the bed. You need to make sure your blood circulation is not impacted. Proper blood circulation is crucial to recovery and healing. It carries oxygen and other nutrition throughout the body. There is one more complication regarding blood circulation in lower limbs post surgery. Anyone can tell me about it? DVT, DVT, correct. Deep venous thrombosis. So, correct. Deep venous thrombosis. So, physical therapy improves blood circulation to the areas of the surgery, even to the lower limbs, and we can avoid deep venous thrombosis. Blood circulation to the other parts of the body as well is to be improved. Other health professionals you may benefit from during your rehabilitation after surgery is occupational therapists, nutritionists, speech therapists, at-home nurses, psychologists, even the support group, uh, other health workers, if there are cancer surgeries, even psychologists and other healthcare group workers are basically help you with post rehabilitation. How long it will take? This is $1 million question. Is how long post surgical rehabilitation takes? Guys, please let me know how long it will take. How long a certain surgery will take? 1 month. Why 1 month? 5 to 6 months. After TKR, they will start working on same day. 6 to 8 week conditioning exercise. To 2 to 3. Again, it depends on surgery. Absolutely right. What kind of surgery? We are not just talking about orthopedic surgery. We are talking about general surgeries. It might be orthopedic. It might be obstetric gynecologist. Yes, the key is to regular assessment and review until the patient is fit. So the rehabilitation doesn't get over until the patient is absolutely fine enough and return back to daily activities. Orthopedic surgeries recover is better as compared to neurological. Yes, can be, can be. Neurological surgeries also can get better in recovery. Depends on surgery. Um, uh, let's come. Let me ask you a question. When we should stop the rehabilitation? When we should stop the rehabilitation? What is the criteria to stop the rehabilitation? I guess when the patient is back to his daily activities, yes, pre-injury state, correct. After recovering, it's after recovering or the patient is back to his daily activities. So it may take 1 year to half year or to a full year. Maybe it depend on the patient. However, full rehabilitation program having reasonable expectation will help you avoid disappointments and focus on the task at hand. If there are no complication and if you stay committed to the rehabilitation process, then the recovery is earliest. Physical therapy is one of the primary tools to healing during our post-surgery recovery journey. So this should be the uh, we should be the primary source for the recovery of the patient. And if there are no complications and patients stay committed to the rehabilitation process, then recovery is at the earliest. And we should set a reasonable expectations to the patient. Basically, we don't set we say that the patient will be recovered 100%. The neurological cases, the craniotomy and cases where there are neurological deficits happen. Uh, I guess we should set a reasonable expectation. Orthopedic surgeries and other surgeries, yes, we can give 100% and we can give 100% recovery to the patient. But I guess in terms of neurological cases, and when you know what is a damage happened to the brain or spinal cord, we should set an expectation to the patient that this until we will do our level best, we will do the 100%, but at least this has to be achieved. We have to achieve certain points, certain steps, and then we'll see about the full recovery. So reasonable expectation is much more. Now we'll come to pathophysiology of the pain. What happens? I said about the pain. Pain is much more important factor in the recovery. Every post-operative case is complaining about pain. They are not concerned about the movements. They are not concerned about their mobility. Most importantly, they are concerned about their pain. What is the pathophysiology of the pain? Pathophysiology of the pain are afferent fibers closely associated with sympathetic nervous system are known to be responsible for transmitting visceral pain. So, basically, afferent fibers, which the sympathetic nervous system is um, there is a upregulation of the sympathetic nervous system, and that transmits the visceral pain. Afferent fibers transmit the visceral pain to the spinal cord and then to the brain. Peripheral nociceptive fibers may enter the central neuraxis by peripheral or somatic or sympathetic nerves. Noxious stimulus undergoes substantial neurochemical transformation and diverge to levels where they activate reflex sympathetic and somatomotor activities. Noxious stimulus is P substances in the area of the surgery, swelling, inflammatory signs can be a noxious stimulus, which forms a neurochemical transformation, which diverges to many other levels and activate reflex sympathetic and somatic motor activity. This nociceptive impulse are transmitted by ascending pathways to many levels of the brain. Further, modulation and reflex activity occurs. Which are the ascending pathways which carries the nociceptive impulse? Anyone? Which are the ascending pathways which carries nociceptive or pain to the brain? Anterolateral pathways, lateral spinothalamic tract, AST, LST. Which fibers of the nerve carries spinal thalamic? A alpha and beta. A delta and C. I guess A delta and C fibers, not A alpha. A delta and C fibers. Yes. So this this causes further modulation in the brain, in the levels of the brain, and causes reflex activity. Manipulative treatment of post-operative pain. Important aspect of the pain management and disease prevention. What is important is pain management and disease prevention. Orthopedic manual therapy post-operatively tend to have less post-operative pain and required less intravenous administration of the morphine. Morphine is a where the pain is there. They use as a pain relieving medicine as a morphine. If we do orthopedic manual therapy post-operatively, so morphine use of morphine, which is harmful for the body, can be administered less quantities. Orthopedic manual therapy and relief OMT and relief of the pain lead to this decrease post-operative morbidity and mortality and increase patient satisfaction. With OMT, we can mobilize the patient in early stages and it decreases the post-operative morbidity and mortality. Uh, Morbidity is due to the prolonged stay in the hospital or prolonged stay on the bed, the morbidity increases and the patient loses confidence. So OMT can relieve the pain, decrease post-operative morbidity and mortality. Soft tissue manipulative techniques and thoracic pump techniques to promote early ambulation and body movements. Soft tissue techniques, soft tissue techniques can be done in post-operatively. Any soft tissue techniques can be done post-operatively. We do scar mobilization, early scar mobilization. So soft tissue techniques and meditation, massage can be done. MFR can be given. Any other soft tissue techniques, myofascial, yes, that is what I said. MFR can be given. Any other? MET can be given. Yes. For some cases, MET can be given. Lymphatic drainage. ERT. What is it? ERT? Proprioception training. Proprioception. Positional release therapy. Passive release technique. PNF. Yes. Lymphatic drainage to reduce ISTM. Yes. 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 Correct. So with this soft tissue manipulative techniques and thoracic pump even techniques helps to promote early ambulation and body body movements. So this is just a diagrammatic representation. What happens in post-surgical pain and what OMT inhibits following pain sequelae? What happens in post-surgical pain if it is the chest or heart kind of surgeries? Then atelectasis, pneumonia, hypoventilation, which can cause prolonged hospital stay. Splinting here is not actual splinting to the part, but splinting is immobilization. OMT is orthopedic manual therapy. OMT is orthopedic manual therapy. So splinting is immobilization or confined to bed is splinting. So it increased pain. This has been taken from the research done by Alexander S. Nicholas and Cheryl, who are doctorate in osteopath. So they say that when there is a hypoventilation, atelectasis, pneumonia, splinting causes increasing pain, EDS causes nausea, vomiting, which causes prolonged hospital stay. I have a question for you. What is ELIAS? Have you come across any patient with ELIAS? Why ELIAS causes nausea and vomiting? Simple question. What is ELIAS? And why it causes nausea and vomiting? And when all this comes, hypoventilation, splinting, ELIAS, that prolongs hospital stay. And we just discussed why prolonged hospital stay is not good for the patient. It affects the mental state of the patient. It is an economical burden. We have to avoid nosocomial infections. We have to avoid secondary complications. Hence, we have to get our patient discharged from the hospital. But these three things will increase the stay. Obstruction in ileum, not exactly. Not exactly. Ileus is decreased GI mobility, reduced intestinal activity causing those symptoms. Yes, I should say no proper movements. Yes, it is a temporary paralysis of the ileum. So decreased. So what happens at the due to the surgical procedures, the ileum, the large intestine or the intestinal movements, there are no proper movement. Its intestinal activity is lost and is temporary paralyzed. It is without physical obstruction. There is no obstruction in the intestine, but it gets temporary paralyzed. Yes, and this causes nausea and vomiting because no, there are reduced paralysis movement. Yes, yes. So this all causes prolonged hospital stay, and we don't want our patient to stay in the hospital for longer duration of time. So what we are going to do is manual therapy, manipulative treatment, interventions. What we are going to do, the main intervention responsible for the hypersympathetic reflex associated with acute post-operative pain arises from the thoracospinal leg segment. Why we discussed? Because of the sympathetic reflex. Why our sympathetic ganglia are placed on the rib head of the ribs bilaterally on the thoracic spine, thoracolumbar area. So the main intervention responsible for the hypersympathetic reflex associated with acute postoperative pain arises from thoracolumbar segment, spinal segment. Corresponding sympathetic chain ganglia line the fascia along the head of the ribs in this region. Kuchera and Kuchera propose that rebracing will produce reflex that clinically reduce the sympathetic activity. Doing this procedure at the levels of T5 to L2 should reduce sympathetic activity to the gastrointestinal tract, which reduces the cause of ES. Herman made a clinical observation that the rebracing at these levels decrease in incidence of post-operative EDS by 99.7%. So what is that as a rebracing procedure? I'll show you what is a rebracing procedure. I'll just go to the directly where he starts rebracing procedure so that we don't lose our time. I guess you got what is everybody got the video, what I was saying about mobilizing the rib angle. Any questions till now? Rib raising. This is called as rib raising. It is more of a osteopathy technique, post-surgical. And there are further more osteopathic techniques, which is uh, which can be done in the acute pain, rib raising to normalize the thoracolumbar region and thereby normalizing sympathetic nervous system activity, and treatment of the thoracic inlet, treatment of the respiratory diaphragm, treatment of the pelvic diaphragm. Uh, Craniosacral therapy also can be used in this interventions. Just sorry. Any questions about rib raising? Can it be used immediate post-op? You can use it technique. If you can slide your hand posteriorly, you can use this post-op immediately. Immediately post-op, yes, you can use, because this is not going to harm, or this is not a push on pull movement. To improve atelectasis, yes, we can use in any surgeries. We can use in any kind of surgeries. The reason behind is rib raising to normalize thoracolumbar region and thereby normalize sympathetic nervous system activity. If the sympathetic, there is a uh, upregulation of the sympathetic nervous system, that you are going to be getting irritated and the pain is going to be there. So all kinds of surgery to reduce the sympathetic nervous, to down regulate the sympathetic nervous system, we in manual therapy do uh, manipulate the thoracic region to downregulate the sympathetic nervous system. But in the surgical cases, we can't do manipulations. We can use this technique. Uh, we can use this technique, I guess, with any cases. It is not going to harm the patient. And what is pelvic diaphragm? There are two diaphragms. One is abdominal diaphragm, one is pelvic diaphragm, and third is thoracic outlet. Thoracic outlet is it lies mm, uh, near your manubrium sternum and across the first strip. So it is a thoracic outlet. That is a thoracic outlet or inlet, you can say. All the major structures, spinal cord, your trachea, everything goes down that thoracic inlet. And there is a respiratory diaphragm, which is a abdominal diaphragm, which separates your thoracic cavity and abdominal cavity and peritoneum. And third is your pelvic diaphragm, which separates your abdomen and lower structures. So in osteopathic medicine, they say that releasing this diaphragm, respiratory diaphragm, pelvic diaphragm, and thoracic inlet reduces uh, reduces the tension on the fascia across the area, as well as increase the mobility, increase the circulation, and it has greater evidences in the osteopathic medicine. Osteopathy means. So this things can be CST, craniosacral therapy. These things can be done post-operatively in any cases. In any post-operative cases can be done. When we are not able to move the patient, this can be done. for any post-operative, uh, even chest cases, abdominal cases, neurological any cases, orthopedic any cases. This all things can be done. Role of manual therapy in lumbar surgeries. I will come to specific to lumbar surgeries. What happens in lumbar surgeries and what is our manual therapy role? Any questions till now? Any questions about osteopathic manual therapy or anything, rib lifting or diaphragms? Uh, we'll go back. We'll go to lumbar surgeries. Persistent spinal. This is the very recent 2023 article. Uh, we usually say that there are failed back surgery syndrome or post laminectomy syndrome. What happens is after surgery, many of the cases, many of the patients has same kind of pain going through. They are going through same kind of pain even after all lumbar or spinal surgeries. Many cases you will see the patient will come to you and tell that I have gone across the surgery, everything is done. Doctor has promised me that there won't be any pain. You will be start walking in couple of days. Everything will be fine. But now, even after 2 months, even after 6 months, this pain is still persists and it doesn't go off. Pain is still irritating me. And for this reason, I have spent so much money. I've gone under so much pain, but the pain has not gone a little bit also. Pain remains. Have you come across these patients? I guess every physical therapist has come across these patients. So what is it? It is a persistent spinal pain syndrome type 2, which describes recurrent or chronic axial or radicular spinal pain in patient with history of spinal surgery and replaces previous term. See, that is what I said. Previous term was failed back surgery. People come to you. The surgery was failed. I can't do anything. Now the pain is still there. That is what we call the failed back surgery syndrome or post-laminectomy syndrome. But this term has been Prager et al. Changed this term to persistent spinal pain syndrome type 2. And this is this usually every physical therapist has come across this pain. And most important question: is it okay to perform spinal manual therapy for lumbar spine post surgery, thrust or non-thrust techniques? Just give the answer. What are you supposed to do? Can you use? Is it similar to rib springing? No, no, not exactly similar to rib springing. No, normal glide can. Non-thrust should be ideal post surgery. This is a tricky question. Is it okay to perform spinal manual therapy for lumbar post surgery? Just think about the question and answer. Guys, I want answer. We have to move forward. Non-thrust technique should not be spinal rotation. No, I think no, no, we, no, no. Most of them are saying no. Did you have a question in your mind? that after post-surgery, after how many days you can, or after how many months you can, or lifetime no. There are some surgeries wherein there is fixation done. In that surgeries, I can understand. In that surgeries, I can understand that there should be no manipulations done, because the fixations might be lost, or they loosen up the fixations. It depends. We are talking about surgery without fixation. Yes, we are talking about a surgery without fixation, which is laminectomy. After complete recovery might be, but without any block fixations. Yes, without any fixation. We are talking without any fixation. I just wanted to know, can we do it post surgery? Yes or no? And after how much time? Post how much time? Post 6 weeks, post 8 weeks, post 20 weeks, post 4 months. General recovery. General recovery. 4 months, 6 months, 8 months, 10 months. Uh, Suppose a patient comes to you after a year saying that I have got laminectomy done, and I have got laminectomy done. My pain is still there. I guess it is irritating my nerves. I get uh, lateral thigh pain. Uh, do you or can you manipulate this patient after a year? Is it safe? Do we do it? Can we do it? Is it safe after a year also? After 4 months, maybe after 4 months. Sir, TJ sir, can you just put some light on this? Okay, we'll ask sir about this, regarding this. Manipulative treatment intervention. Example for the protocol for the treatment of subacute and chronic pain. Treatment for of post-operative patients with subacute to chronic pain after normal inflammatory healing response at approximately 3 weeks. Proper diaphragmatic exertion with respiration should be maintained. Patient should exhibit abdominal wall response for the lower ribs to the pubic symphysis, that is abdominal breathing pattern, to be improved with these cases. It is important to avoid techniques that incorporate unnecessary shaking or overhead arm techniques. This is just post surgery acute case. In acute case, okay, subacute case, you can say acute or subacute case, to avoid techniques which is unnecessary shaking or overhead arm techniques. The thoracic lymphatic pump techniques with arms can be done. I guess lymphatic drainage is a whole new topic, an entire topic to be discussed. So it depends on the surgery, but sir, I just wanted to ask you. Yes, we do uh, the manipulations post surgical. Depends on the surgery. If it is not fixations, we do. We can avoid the segment. We do it above and below the segment, but we do it. We can do it. Yeah. Non-thrust techniques, non-thrust spinal manipulative therapy, what we use in acute and subacute cases. In chronic cases, we can think of manipulations. Yes, we do. What I said right away is flexion distraction, osteopathic mobilization, Logan basic techniques, Craniosacral techniques with blocking, non-thrust osteopathic manipulative techniques, which is mobilization, grade 1 to 4, and instrument assisted manipulation, ISTM. ISTM. So, in this maximum, most used technique is flexion distraction techniques. I'll just show you the video what is flexion distraction technique is. This is to be done in lumbar surgeries. This can be done, but this is the bed they use, the table, assistant table. Hmm. So this was the flexion distraction procedure. We can do this procedure without using the bed, and this is what we teach in GEM classes. Flexion distraction technique can be very effective in the cases wherein it is a non-thrust techniques. It can be used in laminectomy or laminotomy, lumbar fusion, lumbar discectomy, disc arthroplasty, spinal cord stimulation. Any kind of surgeries can be done. Again, this technique can be used. These are just few techniques, 5 to 6 techniques, but Traeger et al. Chiropractic and Manual Therapy 2023, the journal says that there are 103 different type of surgical procedures, surgery or procedure, lumbar procedure. So in every procedure we can do this flexion distraction, and in GEM classes we teach how to do this flexion distraction without using the bed, without assistance. Practitioners who perform spinal manual therapy, most common type of practitioner administering spinal manual therapy was chiropractors. They do manipulative treatments post surgery also. They do crack the segments post surgery also, followed by trained practitioners. Physical therapists are very least, and MD and DO are very least to perform the thrust techniques. This is basically, we are talking about the thrust techniques because we are very cautious about doing this. We are feared what the surgeon will think or what the surgeon will say. So most common was chiropractors who do it. 70% of chiropractors still do post surgery. Spinal manual therapy for PSPS2, most providers use non-manual thrust lumbar SMT, and chiropractors were most likely to use manual thrust lumbar. So we other providers are very cautious in using thrust methods, but the chiropractors still do. I don't know how they do it, but they still do. Spinal manual therapy for PSP is to a systematic review found that mean peak force applied to the lumbar spine in newtons range from 210 to 495 newtons in thrust, while spinal manual therapy, another study reported a mean of 102 newtons for flexion distraction technique. See, even if they do a thrust techniques or we do a flexion distraction technique, We do non-thrust techniques. The results found were same, but the force applied while doing the thrust techniques and the force applied while doing the flexion distraction techniques were half of it. So evidences say 3 to 14% of physical therapists use thrust SMT to manage non-specific low back pain.
I'm allergic.
Yeah. So still the results were same by using flexion distraction techniques and
Did
other
not study. The article did not look at it.
other. So what are the other treatments? The role of the rehabilitation after surgery in patients with low back pain is pain and the systemic review includes randomized controlled trials on the effectiveness of rehabilitation, surgery for lumbar disc herniation, spinal stenosis, and spondylolisthesis. What is our role? Main, again, muscle, same thing we are talking again and again. Pain and disability, reduce pain and disability, avoid muscle atrophy and weakness, stiffness we have to avoid, fear of movement we have to avoid, inactivity in daily living. So we have to make patient mobilize active. Post-operative physical and mental health may be affected over than expected. So we have to make sure we have sometimes we have to counsel the patients also.
I think the state doctor That's for good now.
So treatment is strength stretching. Immediately after stretching, immediately after surgery, you will begin stretching to prevent adhesions from forming, scarring to occur. In particular, you will work on stretching your quadriceps and ham stretches. Might include seated ham stretching, quadriceps flexion stretch, nerve stretches. Will not go deep into this because everybody knows what is seated ham stretch, quadriceps flexion stretches, nerve stretches. What are the generic exercise plan for these patients are pelvic tilts, prone push-ups. If the patient can go, this is somewhere into subacute and subacute cases. After patient is cleared from the surgeon, we can go into prone push-ups, prone leg raise, supine lumbar flexion, sciatic nerve gliding. The patients with sciatic nerves, posterior pelvic tilt, hip and core strengthening. So basic exercise, we'll just go through the basic exercise. Everybody knows this exercise. This exercise are very generic, very clear. We'll go. Initial exercises program, what we do in the patients with the conscious patients are ankle pumps, lie on your back, move ankles up and down, repeat 10 times. Very easy. Lie on your heel slides. These are basic exercise to make the patient active for increasing the blood circulation to the body, throughout the body, and muscles to start functioning of the muscles and reduce the atrophy of the muscles. So lie on your back, slow bend and straightening the knee, and even lymphatic drainage also. If we start with the ankle, then knee, and then hip, then the lymphatic drainage also works in these cases. So lie on your back, slowly bend and straighten the knee 10 times. Because the patient is not so, it is lethargic, is under anesthesia, I might not understand to repeat how many times. We just make them do it 10 times. That is more than enough. Wall squats, when the patient is up, patient can get up, patient can go to the washroom by himself or with the assistant. We can make him do all wall squats if the surgeon clears off. That squats are very simple. Stand with your back leaning against the wall. Walk with 12 inches in front of the body. Keep abdominal muscles tight. So there is a strengthening of core strengthening muscles while slowly bending both knees to the 45 degrees. Hold for 5 seconds, not 90 degrees, just 45 degrees. Just simple 45 degrees knee bend is more than enough. Wall squats, Slowly return to the upright position. Repeat 10 times. Heel raises. Simple. Stand with your weight evenly distributed on both feet. Hold on to the wall or study chair for stability. Raise your feet. Raise your heel off the floor on your toes. Slowly lower your heel to the floor. Repeat 10 times. More than enough. Straight leg raises. Lie on your back with one leg, straight leg. Tighten the abdominal muscles to stabilize your back. Slowly lift leg straight up to 6 to 12 inches. I say around between 30 to 60 degrees. Hold for 1 to 5 seconds. Lower leg slowly. Repeat 10 times. Single knee to the chest. This is somewhere intermediate exercise program because knee to the chest also requires the clearance from the surgeon. Okay, you can do. It is sometimes post uh, post lumbar surgeries or post back surgeries. The doctors or the surgeons ask the patient not to sit, not to bend down, not to lift anything, or no knee to the chest. So if the surgeon clears off knee to the chest, okay, he can do still do. Then we can start with the knee to the chest. Hold for 20 seconds, then relax. Repeat it 5 times, more than enough. Hamstring stretch. Lie on your back, legs bent. Hold one thigh behind the knee. Uh, Basically, this is a hamstring stretch we usually give to the patient, not the dynamic sports stretch we will give to the patient. This patients can hold by themselves and do the hamstrings up to their tolerance level. We are not stretching it. If they are able to tolerate more, they can do more. If they are not able to tolerate, then how much range is available for the hamstrings, they can stretch it. They can slowly, gradually increase the stretch. So hold and relax 20 seconds. And in advanced knee exercise program, when the patient is having good coordination, good balance, then this exercise can be done because and has to be done under the guidance of the therapist because the patient might fall off. So hip flexor stretch is lie on your back near the edge of the bed, holding knees to the chest. Slowly lower one leg down, keeping the knee bent until a stretch is felt across the top of the hip thigh. Hold for 20 seconds, then relax. Repeat 5 times on each side. We will give this presentation will be available on the YouTube, and you can see all the exercises. I guess everybody knows all these exercises they have been doing with the patients throughout their practices. But still, if anybody wants to refer this exercise program, basic, intermediate, and advanced program, they can see. They can go to the YouTube, check the video. They can do it. So usually done in the therapist guiding piriformis stretch, try on your back with both knees bent, cross one leg on the top of the other. Pull your opposite knee to your chest until the stretch is felt, the buttock hip area. Hold 20 seconds, then relax. Repeat 5 times each. Advanced exercise program with the ball exercises, lying on the floor, lie with your lie on your back with knees bent, calves resting on the ball. Slowly raise the hand first, then slowly extend the knee, one leg knee, then do the alternate one leg and opposite hand. This is something which is in advanced exercises. Yes, you will be getting the link to the YouTube for sure. Sitting on the ball, 90 degrees, then raise the arm over the head, lower the arm, alternating, then raise the knee, extend the knee, then lower the knee, then do the opposite arm and opposite knee, and do lastly do marching So this will improve your balance and coordination with core strength, Secondly, Standing exercises, stand with the ball between your lower back and ball. Slowly bend the knees 45 to 90 degrees. Now, in advanced stage, earlier we said that it should be somewhere around 30 degrees, 30 to 40 degrees. Now, 45 to 90 degrees. Hold 5 seconds. Strengthen the knee. Slowly bend knees 45 to 90 degrees while raising both arms overhead. So in this position, you have to raise your arms overhead. If the patient is really good, then he can do. Lying on the ball, lie on your stomach over a ball. Go ahead, slowly raise alternate leg 2 to 4 times. Combine one and two alternating opposite arm, opposite leg. We do it on the bed. The same thing has to be done on the ball. The important thing is not to arch your back. Again, this is very advanced program, has to be under the guidance of the therapist, has to be cleared from the surgeon that yes, patient is good and the patient willingness to strengthen the core. This advanced program is advised. Lie on your stomach over a ball, walk hands out in front and ball off ball until ball is under legs. Reverse to starting position, walk on hands in front, walk slowly, come back. Lastly, only exercises are not enough because patient will do exercise for an hour, 1.5 hours, but the posture when he is working around, if it's a sedentary life or is working in office, posture is must and much important. Throughout the day, he has to maintain posture. I guess everybody might have come across the patients with CABG, cardiac surgeries, open heart surgeries. The patient, the patient tends to slouch because of the sternotomy. So patient tends to slouch. If only exercise will help, the only exercise will not help. Even the proper posture maintenance is very important. So posture corrections are to be done, are to be given to every patient. Pay attention to a posture, like you have to tell the patient both during activities and throughout the day. They shouldn't slouch. They should sit erect, avoid slouching, rounding your shoulders, avoid, strive to maintain upright posture, follow correct postural techniques, ergonomic adjustments at your workplace so that you should sit straight and erect, no slouching to be allowed. Because if the posture correction is not there, the fascia gets tightened, the muscles around the area gets tightened, and how much ever you work for strengthening the opposite group of muscles, the posture still remains the same. And over a period of time, when this posture gets somewhat fixed, then patient then the other complication starts. So we don't want that other complications, add-on complications. If I have taken a lecture on the thoracic thoracic bad problems and the postural problems regarding it. When there is a kyphotic posture in thoracic and the patient is not able to do the lordotic posture or the straight posture, his flexion and abduction ranges of the upper limb has reduced. So if this cases in thoracotomy or lumbar surgeries or even the abdominal surgeries, if the patient is not correcting his posture initially and the posture starts getting fixed, then post post complications like reduction in the flexion of the upper limb and abduction of the upper limb, the range of motions are reduced. And after some time, after a couple of years, they will come back to see, I have got only this much range. I can't do it. It is not the shoulder problem. It is the thoracic problem. And we have the therapist who were looking after him has not addressed the thoracic problem or proper posture at a time post-surgical. Hence, this day has come wherein his shoulder ranges has been reduced. Hence, we have to take care of proper posture. Few things to add up is postural awareness. We can teach this thing to the patient how to correct the posture, demonstrate the correct posture, explaining, tighten your belly buttons, tuck in your tummy, knees slightly bent, shoulder back, scapular retraction, chest up, chin tuck slightly. Let the patient do it. Ask the patient to do it. Correct him. Explain him what is the correct position. Ask him to do it repeatedly, many times in a day, to correct the posture. Exercise is one thing wherein we are going to work on their muscles, group of muscles, strengthen everything. But maintaining posture is very much important, very much important. Simple stretching and strengthening of the extensor muscle group, core strengthening, cow cat exercise, open book thoracic extension, or foam roller, doorway stretch, pec stretch, chair sitting thoracic extension. This are supposed to be done, not exactly post-operatively, but after some time. When the patient is cleared from the surgeon, you see patient is good enough, his wound is healed, the patient is perfectly fine. You can do this kind of exercises. Uh, Again, the references, what we have taken from. Okay, any questions till now? Hope we have finished with it. Finished with the lecture. Any questions?